CYC is a free channel, presents the Word of God for everyone. Your support will help us to continue the mission. Visit our website, cycnow.com. Even $1 will make a difference.
Hello, and welcome again to another episode from our series on Cyc Md. In this series, we are exploring different specialties and speaking with different professionals in regards to their focused area of practice. Today, we will be focusing on the area of an obstetricianist gynecologist, otherwise known as an OBGYN. We will be discussing many issues and topics related to pregnancy, menstrual cycles, and preventative care and screenings. So women, you want to hear this. With me today, I have Dr. Peter Gerges. Welcome, doctor. Pleasure to have you.
Thanks for having me, Mary. Good to be here.
I know you have a busy schedule, and really, thank you so much for taking time out to be here.
My pleasure, anytime.
So we all know that the road to become a doctor is quite a long road, stressful at times. How many years, if we could just talk about your education first, how many years did you have to study?
Sure. Well, if you asked me a couple years ago, I would have told you 100. But realistically speaking, it's probably about 8 years after college. So
Feels like 100 though.
Feels like 100. Yeah, you got high school, 4 years, then you have 4 years of college, 4 years of med school. And then for me, my specialty, it's an extra 4 years, but residency can vary anywhere from 3 to 5. So 8 years total for me since college.
And where do you work now?
I work in a private practice in Brooklyn, New York. I work with 2 other physicians, attendings, 1 male, 1 female. We also have a midwife in our practice and a nurse practitioner.
Thanks. Now, if I could ask you, why did you choose the career of an OBGYN?
It's a very common question, actually, and it wasn't a simple or quick decision. When I went to med school, I was exposed, obviously all of us are exposed to many different specialties. I was always attracted to fields that had a little bit of surgery and a little bit of medicine. And then the advantage of OBGYN is that you get to take care of people for a long time. And that combination of 3 is really what attracted me to the field.
And what do you enjoy most about it?
Pretty much the continuity of care is the biggest thing. You really get to know your patients. You see them through different stages and phases of their life, and you really develop a relationship and sometimes a friendship with them. And that's very satisfying to see that you've taken care of them throughout the years.
So what would you say is most challenging about your job?
There are 2 things that are sometimes a little bit difficult to take care of. The first is dispelling myths and rumors. You know, patients will show up and tell you, my mother said this, my grandmother said that, my friend said this. And sometimes there's truth to it, but a lot of times there isn't. And dispelling those myths and rumors can be difficult. But the more challenging part of my job is reminding patients that an OBGYN, yeah, we take care of pregnant women, which is what everyone thinks of us as, but also, more importantly, we take care of patients who are young and healthy and normal in preventative care. And it's very difficult sometimes to get people to come see an OBGYN who are healthy. So getting that education out there, it's one of the hardest parts of the job.
I sure do know that there's a lot of myths out there, and we're going to discuss them later.
Hopefully, yep.
So, being a male, if I could just ask you a more personal question, do you think many women shy away from a male OBGYN?
You know, it's a question that also comes up from time to time, and honestly, I don't really put a lot of thought into it. I think as a woman going to an OBGYN, you have to feel comfortable. Man, woman, young, old. It really shouldn't play a role. You should go to who you feel comfortable with and who you think can take care of you and who you trust as a doctor down the road.
So let's dig into the field now.
Sure.
What is the role? What is your job? What is your role as an OBGYN?
I view the job of an OBGYN to be threefold. Of course, everyone knows the OB part of it, taking care of pregnant women during their pregnancy and afterwards, maybe even helping them get pregnant. Or in certain cases, trying to prevent pregnancy. Then there's the GYN aspect of it. That's taking care of women's health when there may be issues, bleeding abnormalities, pain with periods, other issues that can come up in women's health, both in premenopausal, postmenopausal stages of life. But a really important part, a third part of our job, and I kind of touched on it before earlier, is preventative care. Making sure you're getting the right screening, make sure patients are healthy, taking care of themselves. And that's an often overlooked part of our job, but I think it's just as important as the other two.
So what would you say is an optimal time for a woman to start seeing an OBGYN?
Well, screening should start at 21. One of the most common screening tests that we do is the pap smear. I think most people are familiar with that. That's where we draw cells from the cervix and look for disease, cancer, precancer. And that should at the very least start at 21. But most OBGYNs would encourage women to see them earlier, mid-teens, late teens. One, to establish a relationship with your OBGYN so you're not uncomfortable down the road seeing them. And two, to make sure that everything is occurring normally in life. Your periods are normal, growth is normal, development is normal, any questions or concerns that you may have in your teen years. So it's always helpful, in my opinion, to see an OBGYN in your late teens.
So you said basically maybe 21 you put as the starting as for sure. And how often after 21 now?
Sure, normal, healthy woman with no problems should see her OBGYN once a year. You don't necessarily need a pap smear once a year. Those guidelines are changing. But you should see an OBGYN once a year just for general health check. One of the most important things your OBGYN will do is a breast exam. That's unfortunately, breast cancer is about 1 in 8 in the United States. So that's a very important test to be aware of, specifically when you're over 40. But other exams as well, and discussions, conversations. So once a year should be the minimum to see your OBGYN.
Yeah, I'm sure many women probably don't follow that criteria.
No, honestly, most young, healthy women only see their OB when there's a problem or they're thinking about pregnancy or getting pregnant.
Right.
And to be honest, most women do fine with that, but it's those few that may have complications that they're not aware of, that it's really important to see your OB once a year just to make sure you don't have anything wrong going on.
So why would you say it's also important? Is it important for an unmarried woman to see a gynecologist?
Sort of for the same reasons. A woman may be unmarried and feeling fine, but her periods may have been abnormal all throughout. She may not be aware they're abnormal, and that could be a sign of something else. Either there's an issue with fertility, although unlikely. More common reasons are, there could be an underlying medical disorder, or it could just be an irregular period. Whatever the case may be, you don't want to discover these issues when you're married and trying to get pregnant. You want to know these things earlier, so you're better prepared for them and helping yourself get healthy and putting yourself in the best situation possible for the future.
So how should a normal menstrual cycle proceed?
There's a range. A normal ovulating woman should see a period about once a month, somewhere between 28 days and 35 days. If the period's coming sooner than 28 days or further apart than 35 days, it may be abnormal. You also want a period to last somewhere between 4 and 7 days. Earlier or later could be abnormal. And the amount of bleeding plays a role as well. Heavy bleeding may be normal, but often is a sign of some kind of abnormality.
So what does it mean? I mean, I hear actually a lot of girls, when we all talk with each other, people say that, girls say that their period is irregular. So obviously irregularity means the cycle is not 7 days, but what else can be, or what can be the reasons for that?
So many reasons. In young women, it's probably just immaturity of what we call the hypothalamic pituitary ovarian axis. See figure 1. And this axis involves many organs that have to communicate with one another in an elaborate way to allow a normal period. Just briefly, the hypothalamus is an organ in the brain that initiates the process, and it communicates to the pituitary, which is a major endocrine organ also in our brains, and releases hormones. Those hormones will talk to the ovaries, which will then allow thickening of the endometrium, which is within the uterus. And if a pregnancy does not occur, that woman will bleed 2 weeks later. Many things can go wrong in this cycle, and most of them are not major. It could be things such as weight gain, weight loss, stress, certain medications, travel. That can all alter the hypothalamus, which will send the wrong messages to the pituitary. So if any of that stuff is going on, that's easily correctable, and it's not really something major, but could cause irregular periods. The pituitary, thyroid disease. Many women may have heard of hypothyroidism or hyperthyroidism. That can also throw your period off, and a simple medication can fix that. The ovaries could not be responding appropriately to the stimulation that they're getting from these hormones. There are certain conditions where ovaries, unfortunately, will not work at a much younger age than expected, way before menopause. These are all just a couple of reasons that could cause irregular periods. The most common reason, to be honest with you, is immaturity. 16, 17, 18, 19-year-old women frequently have irregular periods. And it's just that your reproductive cycle is beginning, and they usually will outgrow it. But you may not know that unless you rule out all these other things. So there could be, those are mostly hormonal reasons. There could be structural reasons. There could be abnormal masses within the uterus that could be causing bleeding. But if there's ever an irregular cycle that falls outside of that range, it probably is a good idea to just be evaluated to make sure that everything's normal.
Right. And what treatment options would you say are available for situations as those?
Sure, lots of options. And it all depends as to what the goal is. Okay. So if you find any of those medical conditions, thyroid disease, diabetes is something that can cause it, or any of those other conditions, you can simply treat those with medication. If it's something that's sort of hormonally related, not structurally, and the woman's goal is simply to have a regular period, treatment often is just birth control pills.
Right.
If the abnormality is preventing her from getting pregnant and she's trying to get pregnant, then you may want medication that improves fertility. So it all depends as to what the underlying reason is, and once you can figure out the reason, there's a treatment available for essentially every reason.
So would you say that would be a benefit probably of birth control?
That certainly is one benefit of it. I mean, the main benefit or the main reason people go on it is to prevent pregnancy.
Contraception purposes, right.
But there's many reasons aside from that to go on birth control. One is regulating the cycle. I mean, if you have an irregular cycle, it's inconvenient. You don't want to know when it's coming, so you're ready for it. So birth control pills can regulate that. Interestingly enough, they can also improve other symptoms of menopause. Premenstrual symptoms can be improved with certain birth control medications. Migraines may be improved, although sometimes it may be made worse as well. It all depends as to the major reason for your migraine. Acne can be significantly improved. So there are other indications for birth control pills that have nothing to do with contraception, just to kind of improve life.
Would you say there's any side effects?
There can be. And I think a lot of it has to do with the particular patient that you're dealing with. If a woman gets migraines normally without estrogen, it's probably not a good idea to give her estrogen. Migraines can get worse. And in patients who have family history or personal history of clotting disorders, estrogen, progesterone can make that worse. In certain people who have a personal or family history of breast cancer, certain hormones may make that worse. So depending on the patient, there can be contraindications to birth control. And again, these pros and cons are going to be individualized, and I'm talking very broad. But you should have a long discussion with an OBGYN or a family practitioner, internist, any provider that gives birth control medication. Discuss the pros and cons and what's best for your particular situation.
Right, and I know there's a lot of birth controls out on the market. And I guess each one is tailored, more estrogen, less estrogen,
Sure.
I guess in regards to the hormones, there's different...
Yeah, as a matter of fact, I'm glad you brought that up. We have gone as a specialty away from estrogen. When my mother, my grandmother, that generation, when they were taking birth control, there's 50 micrograms of estrogen in a birth control pill. The most I've seen now, or the most that I prescribe now, is 25, maybe a 30 microgram pill. Most are 10, 15, 20. We're finding out that the safest thing is to give as little estrogen as possible to control the cycle, and it's working, and it works well. There's also progesterone-only medication. There are contraceptive methods that don't involve taking a pill at all. An intrauterine device, they can be hormone-free or just progesterone. There are rings, there are shots. There's a lot out there, and I think there's pros and cons to all of them. And I would encourage anyone who's got irregular cycles or is interested in contraception or has acne or mood disorders during their period to discuss openly with their provider as to the options that are available and which is best for them.
Now, shifting gears a little, I want to touch over the topic of a miscarriage.
Sure.
How common would you say that is?
You know, it's actually probably a lot more common than people know. Despite going through residency and practicing now and seeing a lot of miscarriages, it's still a very difficult emotional thing on a woman. So they don't talk about it very often. But it probably occurs in 40 to 60% of recognized pregnancies. You won't hear about miscarriages. It's extremely common, but it's not something that alone happening one time should be of great concern. But it is a common event.
And how does that happen?
This again, like unfortunately, everything in medicine has multiple reasons for it.
Right.
The most common reason for a miscarriage, or the one that occurs most often, is an abnormality in the way the pregnancy has developed. When the egg and the sperm come together, the division may not be occurring normally, and you may have extra chromosomes here or one less there, and that's a chromosomal abnormality, and that is the most common reason for a miscarriage. Other reasons you really won't discover unless someone's had multiple miscarriages, and then you start to work them up and figure out what's wrong. One of the more common reasons is a structural abnormality in the uterus. See figure 2. And these abnormalities can be very subtle, like a uterine septum, which is a small amount of tissue within the uterus that sort of keeps the cavity open with a little bit of a divot in the middle. And that can sometimes cause problems with the pregnancy growing. Or they can be very extreme, where instead of a uterus growing as one, it can grow as 2 horns, or it can grow as 1 horn. And so that's not compatible for a child to grow. Those you usually find after someone's had a couple of miscarriages. Then we're looking for other reasons. Why did this happen? And that can usually be repaired or taken care of, typically by specialists. There may be medical conditions that are causing miscarriages. A woman who has very bad diabetes or really bad hypertension or has vascular disease, her body's not pumping enough blood to the uterus to allow pregnancy to grow. So sometimes controlling your medical problems can improve your fertility. There may be issues from the other side. You know, it's not just the women. You know, there could be something going on with the father. You know, there could be some issues with, poor sperm production or abnormal sperm production. And these are just a couple of the things that could be causing miscarriages. Again, I want to make it very clear, if there's one miscarriage, I see women that get very broken down. They feel like they can't have one miscarriage should not make you feel that way. Even two you could start looking into things, but still it's very easy to get pregnant again afterward. Once you start getting into more than 2 miscarriages, that's when you want to start looking for these other causes that maybe are causing these miscarriages.
Okay. Well, other than also like health conditions, would you say maybe extra physical work during the time of your early pregnancy can also affect, or is that also just a myth?
That's a very common question. And to be honest with you, there's no grandmother in the world that won't say, you lost a pregnancy because you worked too hard. Is it true? It's very hard to tell. Even there's still some docs now that will say you need to be on bed rest in the beginning of the pregnancy. My take on it is it depends on what the activity is and what your physical fitness is prior to pregnancy. For example, if someone has poor physical fitness and they're really stressing themselves, then they may not be oxygenating their body well enough, and that could cause a strain on the pregnancy. But all in all, you know, studies have not shown that physical activity or bed rest has really changed the way pregnancies turn out. But you'll still find a lot of doctors who recommend taking it easy in the first trimester. Not so much because that has caused a miscarriage, more so because miscarriages are common under 12 weeks, so we don't know if the physical activity caused it or if it was going to happen on its own anyway. So I really would hate someone to feel guilty and say, you know, it's because I lifted, you know, that day, or I moved something that day, or I was wearing high heels. That's not going to be a reason for it. But it certainly doesn't hurt to sort of take it easy in the beginning.
Right. And so just so that we're all on the same page, probably just one miscarriage or so would not affect future childbearing.
It should not. One miscarriage should not. If you've had two, you might want to get worked up. But even two may be okay. So
how does someone determine if they're infertile?
It's a question that comes up very often, and it's one of the more frequent visits to an OB/GYN. The technical textbook definition of infertility is you've been trying to have a baby, unprotected intercourse, for a full year without success. That's infertility. That's when you have to start looking for why are we having a hard time having a baby. Mm-hmm. To take it a step back, you may have a clue that there's some infertility going on if you have irregular cycles, or they have these ovulation predictor kits. You can pick them up at home, CVS, pick them up at the pharmacy, CVS, Walgreens, any pharmacy, and it's basically 7 to 12 sticks that you urinate on in the morning, and it'll tell you if you're ovulating or not. Those are pretty accurate as well. If you have irregular cycles, or if you're not seeing any positive tests on that, there may be some hint of infertility. But the technical textbook definition is 12 months of trying without success.
So, and this could be either from, I mean, I don't want to just focus also on the female herself, but from the male point of view also.
That's it's either. So that's sort of the problem with these tests. Mm-hmm. For male infertility, it's one test. It's a semen analysis, and that's it. You know, we're pretty simple. There's nothing complicated to us. But for the female reproductive system, it's very complicated, and there are many details to it. So if you were to test a female fertility, it would take many more tests. But either way, man or woman, the definition is usually after 12 months of trying.
And what would you say are probably procedures or evaluations that are in place to improve, assist infertility?
Sure. So we sort of started talking about it already. Once a couple comes to me, or any OB/GYN, so we've been trying for 12 months, we're not having any success. Now you have to look at male reasons, female reasons, combined reasons, or a lot of patients fall into the unexplained. Everything is normal for both, and it's unexplained. For male, physical history, make sure there's no medications that he's taking, smoking, alcohol, any drugs that affect fertility, fertility history, and then a semen analysis. That's pretty much the whole workup. For the woman, it's a little bit more complicated. Same thing, physical, get a history, see if she's on medications, any prior surgeries, any prior things that could affect her fertility, smoking, alcohol, same stuff. And then you want to make sure that the ovaries work normally, usually with blood work. You want to make sure the uterus is normal, there's no structures or masses or anything causing abnormalities in the uterus. That's usually an ultrasound. And then there's a more specific test to make sure that the fallopian tubes, which connect the ovaries to the uterus, and that's where the eggs are released and come into the uterus from. You want to make sure those tubes are open. And that can usually be done by a specialized test where fluid is placed into the uterus, and you want to see it come out of the fallopian tube to make sure it's open. That's the bread and butter for an evaluation of infertility. Mm-hmm. If any of those are abnormal, or you suspect something different, there may be more invasive tests, but that's the cornerstone of the workup for infertility.
Right. And we also want to just also keep in mind that just, birth in general is a gift from God.
Of course.
I know there's a science behind everything, but in the end, there's always a bigger God. And
well, I have many stories I could share with you at some point,
please.
Where patients come in and infertile for a year, 2 years, went to this doctor, went to that doctor, tried this medication, and then they give up and they get pregnant on their own. We have lots of patients who were about to start the infertility workup and they show up pregnant. So yeah, of course. I think if you're in medicine, it makes you believe in God more. If you're doing it the right way, you should see God's work every day. So I second that 100%.
Well, yeah. We always just have to have that little bit of faith, even though when times are the toughest. Definitely. And just know that, God will take the right time at the right season for everything.
Absolutely.
So now I want to jump over to the topic of hysterectomy.
Sure.
What is a hysterectomy before we attack that topic?
That's an excellent question, and you'd be amazed how many women are confused about what exactly is a hysterectomy. A hysterectomy, Ectomy meaning to remove. Appendectomy, tonsillectomy, removal of the appendix, removal of the tonsils. Hyster means uterus. So hysterectomy, in the strictest definition, is removal of the uterus. It does not involve the ovaries. Many women have their ovaries removed when they have a hysterectomy, but it doesn't have to be that way. Even the cervix does not have to be removed with the uterus. You can have a total hysterectomy where you remove the uterus and cervix, or a subtotal where you remove just the uterus. But hysterectomy in the strictest sense involves the uterus.
Now, what are reasons that would necessitate for a hysterectomy?
Sure. I like to break it down into two broad reasons.
Okay.
Life-saving reasons and life-improving reasons. So life-saving reasons, God forbid, come down to cancers. Uterine cancer, cervical cancer, ovarian cancer, usually you take the uterus also. Pre-cancer of the uterus. Sometimes, if it's aggressive pre-cancer, you perform a hysterectomy before it gets worse. So those are the life-saving. Life-modifying or life-improving can also in some respects be life-saving. Patients with heavy bleeding, severe pain, or what's called as uterine prolapse, which is where the organs lose their structure and support and they drop. Those are life-improving reasons. I'm a general OBGYN. I don't deal with cancer, so most of the hysterectomies that I perform are on life-modifying or life-improving reasons.
What approaches to surgery are available, I guess?
Sure. For hysterectomy, basically the approaches are either vaginal. Surgery is entirely performed vaginal, no incisions on the abdomen. Abdominal, and abdominal either is with a traditional open procedure or a smaller, minimally invasive procedure, figure 3. The open procedure can be done either with an up and down incision, known as a midline laparotomy, or a transverse incision. The minimally invasive or laparoscopic procedure is done with small incisions throughout the abdomen, anywhere from 3 to 5, all less than the tip of a finger. The most optimal way for a patient's recovery is to have surgery performed vaginally. No incisions on the abdomen, where there's muscles and nerves, and that's where most of your pain comes from. However, not every patient is a candidate for that type of surgery. Sometimes the uterus is too big, or the patient has had lots of scar tissue or prior surgeries that doesn't allow the uterus to come out that way. The second most optimal for the patient's recovery would be the laparoscopic with the small incisions. And that can be either done traditionally with traditional instruments or with robotically assisted instruments, which is a newer technology.
Wow.
Both of them have a good post-operative result, and both patients state they have lower pain than the traditional large incision. I found that patients who have it done robotically have a little bit less pain. But either of those two options, patients do better than patients who've had a large incision. Again, like some patients aren't good candidates for vaginal surgery, some patients also aren't good candidates for laparoscopic surgery because you have to be in surgery for a long time and they may not be healthy enough for it, or it may be a very large uterus where it cannot be performed. And so patients who have reasons not to do vaginal or laparoscopic would need the traditional open surgery. But if a woman ever needed a hysterectomy, it's important that she talks to her OBGYN about all the options and which one is safest for her. You wouldn't want to do a procedure that causes less pain if it's more dangerous. So it's a balance. But those are the ways of performing a hysterectomy.
Thank you, Dr. Girgis.
Oh, you're welcome.
Pleasure to have you.
Pleasure's all mine.
We hope you enjoyed our episode today on Cyc Md in regards to an OBGYN area of specialty. We hope we answered many of your questions, but there's many more questions in regards to preventative care and more in regards to pregnancy that you want to stay tuned for in our next episode. We will be back shortly with another episode with Dr. Peter Girgis. Stay tuned. Until next time, God bless.